Chapter 11, Disorders of White Blood Cells and Lymph Tissues. So we know that the composition of blood in terms of what makes up blood there are white blood cells, there are red blood cells, and there are platelets. Platelets are the same thing as thrombocytes. White blood cells are the same things as leukocytes. Red blood cells are the same thing as erythrocytes. They mean the same thing. Plasma is the other part of the composition of blood. This is a nice graph to show you how blood cells get differentiated in the body. Not that you have to memorize it, it's just a good visual for you to understand the differentiation of how the erythrocyte turns into the reticulocyte, turns into the real erythrocyte, and so on and so forth. That there are B cell white blood cells, there are T cell white blood cells. The thing to remember on this slide, and it will help you when you're reviewing lab work to understand what is going on in a disease. The neutrophils are supposed to be making up about 65% of the total white blood cell count. The primary job of neutrophils is to fight the pathogen, whatever the invader is. So when we are in the inflammatory response or the initial phase of infection, you will see extremely high neutrophil response to the invasions, and it usually lasts about 4 to 5 days. Eosinophils make up for about 1 to 3% of the total white blood cell count, so it's very rare. And eosinophils are activated for allergic responses and to fight off parasites. So when we see large increases in our eosinophil white blood cells, we know that we're looking at some sort of an infection or allergic response. So it gives us an indicator. Basophils are probably the least active white blood cells in the body, 0.3 to 0.5%. And these are the cells that actually contain heparin and histamine. And so again, with hypersensitivity or allergic reactions, we will see increases in your basophil differentials. So when we usually order a white blood cell count, the normal lab value is 5,000 to 10,000, but we order a differential when we want to understand which white blood cell counts are more prevalent, because it gives us more detail on what may be going on in the body. The other white blood cells that you will see are lymphocytes, and lymphocytes come in three kinds. Either B cells, and the B cells usually create antibodies, T cells, which control the immune response, particularly in cell-mediated immunity, and natural killer cells that kill antigenic cells. Last but not least, we have monocytes or macrophages, same thing. These are antigen-presenting cells that help create the inflammatory mediators. Monocytes or macrophages are about 3 to 8% of the leukocyte account. Lymphocytes are about 30% of the leukocyte account, and agranulocytes would be Agranulocytes are this class here, which means they don't have cytoplasmic granules like other white blood cells. This is just a nice graphic of how white blood cells are differentiated from the stem cells in your body, not for memorization, just for an overall high-level overview of where cells come from. Now, let's talk about some of the pathophysiological white blood cell disorders in the body. That would be leukopenia, neutropenia, aplastic anemia, infectious mononucleosis, and HIV. In leukopenia, basically what we're saying is that we have an abnormally low number of neutrophils for the body, less than 15,000. And we can gradiate the severity of this abnormal low number into mild, moderate, and severe. Some of the risk factors that create leukopenia have to do with the medications that we take, cancer, autoimmune disorders play a role in decreasing the white blood cell count, particularly the neutrophils. When our neutrophil function is decreased, or when our neutrophil numbers are decreased, it has a response that impairs the function of our infection prevention response. Particularly, think about neutrophils being active at the skin level of immunity, be that either the outside skin or the GI tract. Signs and symptoms that we see basically occur because of the impaired immune response. So that normal signs and symptoms of inflammation that we would see in the body are usually blunted or absent, meaning by the time we see changes in the white blood cell count, to be able to diagnose something, the patient is actually sicker than we think. Treatment for this, antibiotics. Neutropenia, or agranulocytosis, means we don't have any neutrophils at all. And these are usually, when you see this in the body, it's usually chemotherapy induced, or it's an adverse reaction to some of the psychotropic medications that we prescribe to patients. Basically, the signs and symptoms that we see are flu-like symptoms. So we see malaise and tiredness. Fever is a sign and symptom, but we usually see this late because of the blunted effect of having decreased white blood cells. This is a serious situation, and particularly we see this a lot when we're treating cancer patients. It's an expectation of what we're trying to do to the body to kill the cancer cells, but in general it kills all of the good cells. So cancer patients on chemotherapy are generally at risk for infection. So they have to do a lot of alteration in their eating, in their ability to be around people, and their immunity systems are severely compromised. In aplastic anemia, this is basically a disease that affects all the myeloid stem cells, resulting in anemia, thrombocytopenia, which is the platelet cells, and agranulocytosis, which is the white blood cells, anemia being the red blood cells. Again, very generalized signs and symptoms that we see: weakness, fatigue, pallor. We get a fair amount of petechiae, which is like a pinpoint bursting of the capillaries. So we get a lot of like little red pinpoint bruises, or full-on bruising would be a later sign. People who are at risk for aplastic anemia are those that have been exposed either therapeutically to radiation or non-therapeutically in the environment. And there are also several toxins and chemicals that exposure to create aplastic anemia in the people that have been exposed. In terms of treatment for aplastic anemia, we look for a varied amount of treatment. Basically, we first see what the cause was. If it's an environmental cause, we want to remove exposure to those environmental toxins or chemicals. If it's a result of some sort of treatment that we're doing for some other disease process, we may actually have to supplement stem cell replacement through autologous or donated bone marrow transplants. We will also supplement with blood transfusions and platelet transfusions to make sure that we can maintain the body at a level where it can minimally protect itself. Infectious mononucleosis, or the kissing disease. This disease usually shows its head somewhere in the junior high to high school age group. It's a self-limiting disease that's caused by the Epstein-Barr virus. Signs and symptoms of the disease are malaise, anorexia, fever, chills, a very sore throat that takes place about 5 days in, a generalized lymphedema where we have lymph nodes that are enlarged everywhere, and an enlarged spleen. So it's a persistent virus that colonizes in people, that is spread by oral secretions, and it has an incubation period that's rather long in terms of what we think of incubation. So you could be exposed and it could be incubating in you for 4 to 6 weeks before we see actual signs and symptoms. Diagnostically, we see an elevated white blood cell count with atypical lymphocytes being about 20% and regular leukocytes being 60% of the white blood cell count. Can't do a lot because it's a virus other than supportive therapy, rest, fluids, aspirin or NSAIDs to keep your fever down. We do generally limit physical activity when the patient is active, in the active phases of the disease process with spleen inflammation, because rupturing a spleen would not be a good thing. Yes, you can live without a spleen, but the functions of what the spleen does for your body are important, and we want to make sure you don't rupture your spleen. Bad news about mononucleosis is you recover, but that Epstein-Barr virus, like other viruses, stays dormant in your body and may reappear later on in life for a disease that we call chronic fatigue syndrome, which is known as an autoimmune infection, autoimmune disease that has similar type of symptomatology, only longer and more prevalent in lasting for that, anorexia and malaise over longer periods of time. There are many types of leukemias, and what you need to know about leukemia is it is a malignant neoplasm of the hemopoietic stem cells in the bone marrow, basically the white blood cells. It creates abnormal readings, particularly in lymphocytes or in granulocytes and monocytes, and that's how we differentiate between the different kinds of leukemia. Acute lymphoblastic leukemia, ALL, or acute myelogenous leukemia, AML, and you can also have chronic versions of leukemia. In the acute phase, or in acute leukemia, the white blood cells proliferate rapidly, it lasts long, and it interferes with the maturation of normal blood cells. It's very easily spread throughout many different organs because it originates in the blood cell, in the hemopoietic system. It is one of the most common causes of cancer in children and adolescents, and it often spreads to the liver, the spleen, and the lymph nodes, causing enlargement, and that's generally how we... The other kind of white blood cell disease that we see, we call lymphoma. And lymphoma is usually differentiated into two different kinds, either Hodgkin's cell lymphoma, where malignant B cells invade your lymphoid organs, or non-Hodgkin's lymphoma, which can be either B cell or T cell spread. The incidence of both of these lymphomas are higher in whites, particularly in the US and Canada. Hodgkin's lymphoma is found more prevalently in younger people, 15 to 40s, and non-Hodgkin's lymphoma is usually found in people over the age of 60, unless they've had some type of exposure. We know that those with the Epstein-Barr virus are more at risk because of that virus, and we also know that people who have immunocompromised bodies that have immunosuppressant diseases that they're taking medicines for, or cancer or transplant patients, are more at risk for non-Hodgkin's lymphoma later on in life. If someone has a family history, there's a higher increase. And if they've had some sort of environmental exposure, whether that be through chemotherapy or rheumatoid arthritis drugs or radiation, we know that those treatments that we give create a later higher risk of lymphoma. We also are beginning to see links with obesity and lymphoma, probably more related to that that inflammatory response, that constant chronic inflammatory response. So with both of these diseases, whether it's non-Hodgkin's or Hodgkin's lymphoma, the signs and symptoms that you see are painless, swollen lymph nodes, a weight loss without trying, fever and night sweats, itchy skin, fatigue, malaise. With Hodgkin's lymphoma, we generally see the lymph nodes in the chest, neck, and groin to be inflamed, and with non-Hodgkin's lymphoma, we tend to see abdominal inflammation, lymph node inflammation. How do we diagnose this? Well, we diagnose by taking a biopsy. So again, these are both cancers. What we know about cancer treatment is I have to get a piece of it and I have to stage it, if you will. in order to be able to know how to treat it. So we're going to take a biopsy. We're going to do CT, MRI, and PET scans to see where there are lymph nodes that are inflamed. In Hodgkin's lymphoma, there's a particular cell that we see called a Reed-Sternberg cell when we get that biopsy. And we also might see in our baseline blood work an elevated sedimentation rate, which we often see elevated ESR due to the acute inflammatory response or chronic inflammation. Surgery involves, or treatment involves surgery. We need to take out any large masses, get as much of the cancer out of the body as possible. There may be varying forms depending on staging of whether they get radiation or chemotherapy. And depending on how far along it is, we may have to resort to immunotherapy, usually in the later stages, and stem cell transplants, again, in the later stages. Which one of these is more treatable? That would be the non-Hodgkin's lymphoma. Remission is successful in 60 to 80% of the cases. And what we have done with this kind of cancer, lymphoma, is that we generally can get it under control and put it into a remission stage for long periods of time, although we may see that it comes back, it recurs frequently throughout the lifetime of the individual, more in sort of a chronic disease format where they have to go in and get treatment to put it back into remission again. Multiple myeloma, what you need to know here is this is a disease process that we usually find when we have a pathological fracture, meaning we have a fracture that occurs without a cause, and the tumors are generally in the bones. One of the first signs and symptoms of this kind of cancer is bone pain, and then we may see thrombocytopenia with the purpura, weight loss, and weakness. We usually diagnose this through looking at your blood work. We will generally find that there is an anemia and that there are very low numbers of erythrocytes, leukocytes, and thrombocytes in the red blood cell counts. We do a bone marrow biopsy to check this out. We also may find what we call Bence-Jones proteins in the urine, so just think protein in the urine. And again, a low kidney function with a high BUN and creatinine, because this generally creates a high calcium in the body, a retention of calcium. Again, because it's sort of involved in the inflammatory response, we'll see an elevated ESR rate. Treatment of multiple myeloma is chemotherapy and stem cell bone marrow transplant to get rid of the bad bone marrow and put new bone marrow in that will proliferate bone production again, rather than what takes place in the disease where the osteoclasts take over and break down the bone at a faster rate.